Hi, I'm Dr. Choll Kim from sunny San Diego, California, and I want to talk to you about cervical disc replacements. So you're probably wondering, what's the difference between a cervical disc replacement and an ACDF? You've probably heard that term a lot because the ACDF surgery is probably the most common surgery that we do in the neck. It's also one of the best surgeries that we do, but more on that later. The ACDF surgery is a fusion where we basically make two bones become one bone, and it does not move. You probably surmise that from the word fusion. A disc replacement is like a knee replacement, but tiny and cute, that goes inside the neck between the bones in place of the disc. Here's the interesting thing. The reason why you have surgery for both those implants are very, very similar. So in some cases, clearly you want to do a fusion, and in some cases, clearly you want to do a disc replacement, but there's this very large gray area of trying to decide. On the one hand, should I do a disc replacement? On the other hand, should I do a fusion? Here's how I look at it. You want to try to do the disc replacement and maintain motion whenever possible. So if you have a 50-50 decision, I err on the side of the disc replacement. Maybe even if it's 51%, I nudge it over. For the patients that are on the fusion side, this is what they tend to look like. They tend to have a clinically significant deformity. The most common is something called kyphosis, which is when your neck, instead of being gently curved backwards, it's kinked forward like that, and your head tilts forward. And that's especially bad because your head is like a bowling ball, about the same weight. And if you don't think that that's heavy, next time you go to a bowling alley, pick up a bowling ball and carry it around, but don't put it down, and see how long you last. If you can last 20, 30 minutes, I'll be surprised, but we do that all day long. So if you have kyphosis and you put in a motion device and don't do a fusion, that kyphosis is going to get worse because there's nothing to stop it. Whereas if you do a fusion, you can realign the spine, and then using screws and a plate, I use a zero profile plate, but a plate even still, you can keep it in that position until it heals into a single piece of bone. Now, most patients try to convince surgeons to do a disc replacement even though they need a fusion. Try not to do that even though you're not going to be able to help yourself, because a bad disc replacement surgery is way worse than a good ACDF surgery by far. And here's the weird thing. The neck and the lumbar spine and the back, the discs, when you fuse them, you don't lose that much motion because the discs are not a locomotion joint. Your elbow, locomotion. Your knee, locomotion. If you were to fuse my elbow joint, that'd be huge. I wouldn't be able to slap myself in the face. And I need to do that every once in a while. But the cervical spine and the lumbar spine, in a normal, young, healthy patient, each segment only moves about 10 degrees. And most patients that need surgery, they don't move that much even. So you're not losing much motion, at the most 10 degrees. In cases where realignment is more important than motion, you should have a fusion. So if you're the patient that's lucky enough to be a candidate for the cervical disc replacement, congratulations. It's going to be awesome. When you go to your doctor's appointment and you see the surgeon for the first time, this is what it's going to most likely be like. The surgeon's going to want to know how much pain you have, and more importantly, how this pain affects your function and your quality of life. So it's not just to have enough to just have a lot of pain. That pain has to have some meaningful effect so that when the pain goes away, you gain function. So you can't play golf now, we treat the pain and now you can play golf. Because we're always trying to balance the risks and the benefits. After that visit, and it may be more than one visit before you and the surgeon have decided that you should proceed with surgery. Once you've decided to proceed with surgery, here's the few things that you can do to help the process and maximize your chances of a great recovery. The first thing is really boring, and it's more kind of logistical. Before you have surgery, we need to make sure that you have been tuned up to the best extent possible. And if you have any medical problems that need to be fixed before surgery, we should identify those quickly. So help us out by coordinating with your primary care doctor and any other specialists all the evaluations and tests that you need to get you cleared for surgery. Once you're cleared for surgery, then things will move forward very quickly with the scheduling and then a bunch of paperwork appointments, including the appointment with me 1 or 2 weeks before, called the pre-op appointment, where you fill out a ton of paperwork and then you watch my favorite video called the Informed Consent video, lasting 22 minutes and 54 seconds long, which you have to watch in its entirety. I will beg you. I'll be very sad if you don't watch it, because it has the answers to all the frequently asked questions about surgery, what to expect when you're getting to the hospital, what's going to happen afterwards, etc. On the day of your surgery, you'll probably have to get up very early in the morning and get to the surgery center of the hospital, dark 30 hours, basically. And the surgeon will not be there for a long old time, trying to get too resentful, but the nurses need to do a bunch of stuff, and they need a lot of kind of buffer to make sure that we don't have any unanticipated delays. Delaying in the OR is terrible, but surgeons can be late. That's a different topic. Once you go back into the operating room, it'll probably take half an hour to an hour before they even start the operation, because they have to put you to sleep. That's the anesthesiologist's job. They have to position you on the operating table, and it has to be perfect. And then you need to bring in all the equipment to do the surgery, and then we need to prep and drape your neck, and then we need to scrub up and get all clean and gown up and put on our gloves before we start the operation. It should last for about an hour per level. So if it's a 1 level, it'll probably last an hour from skin to skin, maybe an hour and a half. I tend to take a little bit longer because I'm a little picky. And then once the surgery is done, the patient will go to the recovery room, and they'll probably need to recover for about 2 hours. And then most patients go home the same day or stay just 1 midnight, like a 23-hour observation, and they go home. And most patients have a follow-up in 1 week, 6 weeks, 3 months, 6 months, and a year. And during each of those visits, there is a progressive increase in your activities, your exercises, your rehab. And I personally basically try to customize it, because I'm amazed at how some people, it's like nothing happened to them. And then there's delicate people, dainty, they don't like pain, and they're going to take longer. They can't help themselves. So the best thing to do is optimize their rate of recovery by customizing it, and sometimes it requires more visits. Depending on how you respond to surgery, you'll get PT that then gradually increases your exercises. And I would like to just emphasize that it is really important to develop an exercise program after surgery that you do on a regular and consistent basis, just like watering a plant. You can't stop watering a plant once it gets healthy and big. You have to keep on watering it so it stays that way, because it's a living thing. And muscles are like that. It needs to be exercised on a regular and consistent basis. And the goal of those exercises, the goal of the rehab, is to work on improving the strength and coordination. The coordination is probably more important than the strength. The coordination of all the muscles that surround your neck, so it acts like the world's greatest neck brace and allows all the forces that go across your neck to be evenly distributed. And because the neck is kind of smart with hundreds of little muscle fibers, potentially it can unload abnormal forces across a diseased motion segment. And that's how the body kind of compensates for that segment, by kind of putting all the pain into the other levels. So after surgery, you want to work with your physical therapist like you would your trainer. And you want to basically use this opportunity to get really, really healthy and fit, because that's the best way to avoid the need for future surgery. That's the best way to maintain the good results until you go to heaven. And that's the best way to live a long, healthy, active life, because if you do that, there's a bunch of other things that will get better. I've been speaking about cervical disc replacements and ACDF surgeries, but I just want to let you know that those are all generalized statements. So make sure that if you are going to make a decision about surgery for yourself, that results may vary and every patient is unique and individualized, and it's really important for you to see a caring doctor that is a good listener, that gets to know you and help you decide on what the best course of treatment is for you. So, good luck.